keeping one, and then also making that process more efficient, because certainly there are ways, good ways and bad ways to communicate with your mentors, delegating responsibility, our research pipeline, and then really like some kind of tips to be efficient both in the clinical setting and in the research setting as well. So the timeline piece is the question that we always ask is, am I too early or am I too late to start applying for these types of awards? And the answer is really you're never too late, because I was one of those people. So I'll take you through that process. And one of the things that Brenda and Amy were kind of talking about is, what do you wish you had known? And I'll take you through this left side of the screen as the ideal world of kind of setting yourself up for research, both in residency as a fellow and junior faculty. But really, you know, in those early years of your child neurology residency, identifying institutional mentors, finding the right fit, finding the right lab. You know, I have found that in working with other people, some show up to residency on day one and they say, I'm going to be applying for NIH funded awards, you know, in my PGY4 and my PGY 5 year. And that's great if you know that that's what you want to do. If you look over at my John's reality side, I mean, I barely thought about making a case report in the first 2 years, and then I realized I was working too hard and couldn't handle that. The second piece of that in the PGY 3 year, really in the ideal world, is kind of developing that specific hypothesis, but also focusing on learning the clinical neurology. I think that in many programs, your PGY 3 year is your most intense clinical one. But at the same time, if you've walked in with a mentor and start learning some of the research methods, that's going to be a pretty helpful thing to do. That is compared to what I was doing, which was kind of finding that rare disease was an interesting field, but still was searching for a mentor and trying to find the best way to actually, take that and research on it. For PGY4, thinking about
one thing, everyone please mute if you are not John. Thank you.
For PGY4, working with your program director to find that dedicated research time. This is particularly important for the basic science researchers or people who need to be working in a lab, because if you're having to go on service, be on call, it's not going to be the most conducive to developing that type of research environment. And even if you're doing clinical or translational work, I think that that's an important piece too. And then certainly working with your mentor team to get that research really established in that year. On my end of things, this was the first time that I had actually found a mentor to actually work with, and we started writing, a case series essentially at that point, but it still was not this right fit hypothesis, and I still didn't really understand if I even liked research at that point. So certainly I was in the, we'll call it delayed category, as compared to the, the perfect world scenario. And then really when you're looking at that PGY 5 year, that's the time where we can, you can start to actually get collaborations, work on that big publication that's going to serve as your prelim data for further studies. And instead of doing that, I was signing up for a fellowship on the opposite coast in an unrelated field and doing all of probably the wrong things in the long run. But what actually ended up happening was I was able to publish some of the research that I had done in residency, found a new mentor at my institution where I went for fellowship, and was able to actually craft that into the more K23 route. More by accident than anything, I assure you, but it was something where the right pieces fell into line with me, whereas actually if you're kind of going down more of a standard and more methodical route, it will be even more easy for you. And then in the perfect world, obviously getting awards, being funded, and then being a highly anticipated recruit when you find your first faculty job is also a great way to do things. For those of you sports fans, I included one of the better comebacks in basic in most recent football history, but you can come from behind like I did. You don't have to follow this pre-prescribed route to getting extramural funding. I will say that the biggest things, if you're in that category of, hey, wow, I'm more like John, I didn't realize that I should be doing all of these other things, get mentorship, find somebody, even if it's not the right person at first, find somebody, and then really don't be afraid to use your program director, chief of the division, chair of the department. The squeaky wheel gets the grease, and if you can say, I'm really interested but I don't know who to reach out to, they can help connect you often to find the right people. You can start small. You know, I think that the other impulse that people have is, well, so I'm behind, I need to really catch up and I need to start publishing. I just do all of these things at once. And that actually is probably going to harm you more than help you. Link in with a lab or a team or your mentorship group. If you're research naive, go through the process, develop a case series, case report. I mean, that's okay. Especially if you know the disease area that you're interested in researching. These are things that can help supplement and say, all right, this researcher has a track record of actually working within this disease state, within this field. And then certainly you need to be resilient. Your first lab, your first mentor may not be the right fit, and that's okay. The big thing is that you can't get discouraged. Many people that I've talked to, and myself personally, have gone through the process of being in an environment where the research becomes very tedious. It becomes less interesting because you're having not so great interactions. So the joke that I like to make is that you have to, like in sales, you have to always be closing, but in on your research goals. So use each experience to kind of build on the next one. So that way, when you're going into that next experience, whether it's with a different mentor, with a different lab team, you can know what didn't work for you before and what did work for you before, so you can make the most efficient use of your time in the next experience. So some tips, like we were saying, from the clinical end of things, it's okay to get involved, especially if you don't come from the big research background that many prospective trainees do. It's okay to do smaller types of retrospective studies. These can be easily done at a single institution. Often academic centers have entire clinics that are dedicated to specific disease states. Be narrow and focused. I mean, the impulse for me when I started to look at even just a case series was, I want to collect every single data point possible. I want to be the biggest and best study on XYZ, and I realized very quickly that that was not going to be helpful clinically for what we were trying to publish and what we're trying to promote to the the academic literature, but also it was not going to be particularly helpful from a time utilization standpoint. So really crafting that focus, one or two things that you want to answer in your study, putting it together, and then generating that data from there. If the disease is rare, that can be a little bit difficult too. So reach out to others in the field. Don't be afraid to ask your mentor or ask your program director, or even the chair of the department, chief of the department, for help. Who do you know who works on this certain disease that I'm interested in? And you'd be surprised, child neurology is a very small and generally friendly community, where you can reach out to people via email and get a response back quite quickly. And you'd be surprised at how easy it is to ask and how much you may get in terms of resources and data from people at other centers as well. So some information on time, and again, this may not be applicable to everybody right now, but just something to think about, and certainly we can go back to it as well if people have more questions. So this is what my dad always asks me. He doesn't think I actually do work when I come into the hospital. The way that I have things set up right now is more of a 80-20 situation. So 20% of my time is spent in clinic. I am a neuroimmunologist. I deal with multiple sclerosis, neuromyelitis optica, autoimmune encephalitis, all that fun stuff. I have it broken down so that 20% also carries over to inpatient time and some neurocritical care coverage as well. For research, I kind of dip into many different areas. So certainly I'm involved in clinical trials, being in the multiple sclerosis space, but I also have funding through nonprofit foundations, and then industry non-funded clinical trials as well. And then certainly I've sent off a K23. We'll see, keep my fingers crossed, and hopefully we can get some extramural funding on that. But when we think about research, yes, there's the NIH funded route, which is really kind of the bread and butter of academic medicine, but there are multiple avenues, especially for junior faculty and early career persons, to supplement your actual research activities.
John, this is Amy. Just so people get a sense, what does your institution consider your clinical time or clinical FTE to be, with 2 clinical sessions a week and 6 weeks of inpatient coverage?
Yeah, so basically when the clinic formation comes out, it's basically 0.1 goes for every half-day clinic. And so you have essentially 10 sessions throughout the week. When you're on service, you don't have clinic, and then they adjust that time of kind of inpatient to match up with the outpatient time. But usually for every 0.2, it will be 6 weeks of total inpatient coverage. Of course, we have a split service. We have neurocritical care
So
in general.
this is considered a .2 at your institution?
Correct.
Wow. Okay, I'll tell you by NIH guidelines, at least that we were given for the K-12, this would be considered more like 30%.
Oh, wow.
Yes, each inpatient week. If you think about it, each inpatient week, if you're doing, assuming you're doing full-time clinical, is the equivalent of 10 clinical sessions, right? So you have your one, so you have a lot of extra there. So just something for people to keep in mind when they're working with their institutions to write letters for things like things like the K-12, your institution is going to be asked to write a letter regarding clinical activity and what you'll be doing and what 25% clinical activity would be. If we saw this on the K-12, I can speak as a co-director of the K-12, we would say this is more than 25% clinical activity. Usually you get about a 0.02 for each week of inpatient coverage. So 0.02 times 6 is going to be, 12% plus your 10 is going to be plus 20%, right? Because 2 half-day clinics is 20%. So it's around 30% total. Just to keep in mind, because that can, if your institution is stating more clinical activity than actually the 25% that you're committed to do for a K award, it will hurt your application. So it'll hurt you, not them. So it's important to know those numbers and check them when you get your institutional letter of support.
Great point. And I think that, one of the interesting ways that we break it out too is our neurocritical is counted as a half, because we're only rounding in the morning, and then it bounces back to the inpatient service. So obviously that's what I was trying to say, is each institution is different how they structure their time. And even for EMU coverage, I'm certainly not an epileptologist, but how does that factor in? So all little pieces to consider, especially when you're crafting your percent time. Just a little bit more about dividing time, really just some kind of basic rules to consider when you're at that phase. First thing is that you're not a resident anymore. You don't have to work 100% and often 150% of the time. So high clinical volume is going to hamper your research. That's why many of these early career grants are designed to protect your time and make sure that you have at least 75% of your academic load being research oriented. The second piece of that is knowing that you also need to protect yourself. So ask for protected time, even if it's before these grants are coming in. It's going to be difficult to craft your own grants or develop that prelim data if you don't have that time for yourself. And then, something that I'll kind of hit at a few different points in the discussion, as well, is that it's okay to say no. So early career, whether you're a resident, fellow, or junior faculty, you're going to be asked to do many, many things, and you're going to have the energy level to do it. I say this because I feel like I always say yes to things, but you have to really ask yourself at the end of the day, is this going to help me achieve what I want? Is this going to help me get to my end research goal perspective? And if the answer is no, it is perfectly okay to say no, but also be wise about how you say it. You can, we'll talk about ways to approach saying no a little bit later in the slide deck, but it's an important piece because you're going to be asked to do almost everything right off the bat. The other piece that I'll say, just because I was generally unaware of this, is know your track and your promotion schedule. It's not something that I think you necessarily need to obsess over or really even think about outside of, what are my time checkpoints, but it is an important thing. It varies by institution. I've posted it. I think this is an example from Duke that they had online, but know where you're at, know where your checkpoints are for where you have to be at that kind of 3-year, 5-year, 10-year mark. Not something, again, that you need to obsess over, but it's good to have that in the back of your mind when you're applying for grants.
And this is Amy. I'll just chime in one more thing. So it is totally okay to say no, but it's also okay to strategically say yes. So you don't have to blank, just always say no. You just need to think about when, if this is really something that is going to benefit you. Also, in terms of knowing the timeline for promotion, it's also good to assess that yearly. So you should be having some form of an annual review with your supervisor, division chief and/or department chair. During that review every year, if they're not going over your promotion timeline with you and where you are in the process. And if you are on track, you should ask them to do so, because it's really helpful, you know, doing this proactively and checking in every year to make sure you're making progress is a lot less painful than suddenly realizing at year 5 or 6 that you're in a big deep hole.
Great point. So just some tips on time, and again, this is more for that, you know, transition to junior faculty, but it's okay to come up and draft it yourself as, these are my 5-year targets, this is how I want to break down my time. The more specific that you can be in terms of what you want to be doing, what your end goals are going to be helpful. I just included this image on the side over here. This is kind of what my initial draft was when I was just realizing that when applying for jobs, it is a good idea to have a % breakdown of what you actually want to do, because the #1 question that you're going to get asked is, well, what do you want to do? And it is helpful to actually think about these. That second point, though, and I think this is actually remarkably important now in hindsight, is, you know, condense to be flexible. Make sure that when you're in clinic, you're in clinic. When you're researching, you are researching, and that you're not doing both at the same time. Even though you can multitask, and coming from the residency fellowship realm where you're asked to do 15 different things at once, that can be okay in that environment. But if you're really going to be focused on crafting out a research career, you can't be answering Epic or PowerChart, you know, messages and taking patient phone calls in the middle of an experiment or while you're writing, because it's just going to result in poor clinical care and poor research production as well. So if you can stack things on the same day, clinically or research-wise, it's going to be very, very helpful, and it was very helpful for me to actually arrange that as well. So some notes on efficiency. First up is mentor efficiency. This is something that I cannot stress enough.
Yeah, they know when you're going to be available.
Yeah. So, you know, when you're actually being able to communicate with your mentor, you know, you want to make sure that you're respecting their time, they're respecting your time, and you're not going into meetings without any idea of what to do. So when you have a meeting, set an agenda. I usually recommend to limit that to just 3 discussion points and have specific asks. So if you're having a problem, say, I'm having a problem with this, and then come up with a solution on it. So this is the problem. This is what I think we could do, and then get the mentorship or the mentor's feedback. That's going to limit and narrow kind of the expansive discussion, and obviously some of that goes along with how your mentor communicates with you. If you have a very verbose mentor who tends to go off topic, limiting that actual discussion and saying, this is specifically what I need you to do, can be extraordinarily helpful and get you in and out of those meetings. Emails are the best and the worst thing in the world, but really nobody's reading an email after about 100 words. So be specific, be targeted. I usually recommend just doing bullet points, or using a 1, 2, 3, so that way when a mentor is responding, they can easily say, regarding #1, up, up, up. Regarding #2, up, up, up. It makes the email response a little bit easier, and then you can also, with emails, as you should be doing with meetings, is what is the turnaround time? To say, I need help with this within 2 weeks, or this is due within 3 weeks. Can you get me this letter of support, or communicate with this other collaborator in 2 weeks, so that way I have it in advance. Another big piece of this, and this obviously goes both directions, but be reliable. If you say you're going to give something or send something in by 2 weeks, send it in by 2 weeks. If your mentor starts to get the impression that you are unreliable or you're not following up as you should be, that doesn't necessarily change their behavior, but also sets up a poor precedent and poor communication between you all. So be reliable, be consistent, and be honest. I mean, you can say that you're having an issue, this is what is causing a delay, but if it becomes a track record, your relationship with your mentor is going to suffer, because they're going to inevitably ask, well, if John can't get things on time and it's always a week late, what's my incentive to get him this stuff when I've said, I would do it in a week, or whatever it may be. The final
and
piece
also,
of that,
John, I would point out, give your mentor or your supervisor, whoever you want a letter from, time. It is poor form to ask for a letter 2 days before it is due. Your mentors and supervisors are busy too, and that just annoys people. So even if you get the letter, it may not be as effusive as it would be if you gave them more time and did not piss them off by asking them for a letter on too short of a time scale.
Yes, and more time is always better. The other piece of this that I'll just kind of bring up is balance the updates. Your mentors should know what you're doing, but at the same time, as many of you are probably experiencing now with the hundreds of COVID-19 email updates, when you get 100 during the day, it just becomes less meaningful. Same thing with your updates. Balance them, make sure it's pertinent, make sure it's targeted, and that way your mentor can feel that they're actively involved, or intervene and say, hey, didn't you say you were going to do this before that, or whatever it may be, so that way it's clear, it's updatable, and it's not overwhelming them where they're just deleting the emails as well. I will say within those updates, try to be as positive as you can. Research can be discouraging. You're going to get an article rejected. Your experiment may not work out. You're going to encounter some type of biostatistical nightmare. Be positive, offer a solution, and try to work through it, and always be asking for help if you really need it. Delegating responsibilities both in the clinical and the research end is really important. So I always recommend that everybody has a go-to person for whatever it may be, both on the research and the clinical end. In the clinic setting, having your support staff be able to do the follow-ups, clinical assessments, let them know what your style is, so that way you're not going through the frustration of saying, well, they didn't get the head circumference and now I have to take the extra 2 minutes to do that. Reducing your frustration is going to be much easier if your team knows exactly how you like things and what you need to have done, specifically for those clinical assessments and follow-ups. Your authorization team, get to know them. They're going to be the people who do the prior auths, the peer-to-peer scheduling, all of those time-consuming outside of clinic things. Know your schedulers as well. If you're a person who is okay splitting a new patient appointment and just putting into follow-ups, setting that standard of saying to your schedule, hey, you can do that anytime, you don't have to ask me, can also cut down on the communications. And then even for your triaging physician, I didn't really understand that this was as important as it was until this year. Buttons that you want to see are more focused in terms of only seeing patients with neuroimmunologic issues, but if you're in general neurology, you can say, these are the things that I want to see, or these are the things that I don't want to see. And there may be flexibility institutionally for things like that. The research pipeline is also very important. It requires ongoing vigilance, however. So keep track of your grants, know the times of year that they're due. What is upcoming can also be very helpful for preparing or bringing out something from an archive to reestablish and bring into a grant. Keep track of the opportunities, both intramural and extramural, and then finding and networking with collaborators is another important piece of this as well. Always be asking yourself, not necessarily on a daily basis, but is your study on track? Work closely with your research team, your coordinators, and continually reassess your recruitment for projects if you're in a clinical or translational setting, and get the feedback from patients that are enrolling. What was easy, what wasn't? Because that can really modify how many patients you're able to enroll, which is particularly important in rare disease states and things of that nature. One important thing is it's hard not to compare yourself to others. So always compare yourself to your own goals, your own targets, and that can be established with your mentorship team, the chair or the chief of your department, but trying to avoid comparing yourself to co-residents, co-fellows, people who are 1 or 2 years ahead of you on the junior faculty realm is an important piece of this as well. So as much as I don't like the PDSA cycle, because it has become a little bit bastardized in the quality improvement realm, this is really something that is helpful for when you're trying to think about how can I be more efficient, specifically in the clinical and the research settings. So in terms of clinical efficiency, have your notes be on time. When you start to get delayed, they pile up, they cause more problems down the road. It decreases the quality of the notes that you're actually writing, which can be used and helpful later on. I am very pro technology, so I say make your templates, only have a dot phrase that brings in all of the things that you normally do, just cuts down on the total time that you have to invest in each new note, especially those new patient consultations. Be methodical. So when you're putting in your notes, which meds were given, especially for epilepsy patients, which meds were given, why were they stopped, why were they started, what was the timeline of the clinical development, these little things can actually make your peer-to-peer calls, your prior authorizations go through with a much higher rate of success, because that's the information that many times the reviewing physician or the reviewing insurer wants to see. And if your system has the ability to make order sets, common labs, procedures, etc., that can also really cut down on time. So whenever you're able to use the IT services or the technology base to improve your efficiency, I would highly, highly, highly recommend it. Develop a workflow with your patients and be consistent. So, working with your clinical staff to say, when we have a patient with Down syndrome, when we have a patient with multiple sclerosis, these are the things that are important. These are the things that I want done, can actually help things move a lot more smoothly. When your MAs, when your nurse practitioners, when your RNs are more aware of why you do the things that they do and understand it, it's going to actually facilitate those patients to have a better workflow as well. Kind of gets to that same point, but a knowledgeable team is a helpful team. So even if it seems silly sometimes to explain why we care about, let's say, blood pressure in a patient with Down syndrome, those are things that are going to be important for your staff to understand. Oh, well, that's why we do it, so it's important. So I want to make sure I get high quality. Or, I have to get the most accurate head circumference because in a neonate who's coming in with developmental delay, macrocephaly is really important. And kind of getting your team on the same page for why you do the things that you do. Documents, always save everything from appeal letters to school letters. Again, this is something going back to notes where you can template, make everything into a template, which is really going to cut down your time, especially for the annual, epilepsy medication, school notes for missed appointments, all of that sort of stuff is going to be very helpful. And if you're seeing psychogenic non-epileptic seizures, please develop your own note for it, because that will save you oodles of time later on. For clinical efficiency too, again, this goes more for kind of the early career physician or junior faculty. When your referring physicians are sending you a patient, they want them to be seen quickly. That's like the whole appeal of sending somebody to a junior faculty member. So be mindful how you advertise. If you come in and you say, I'm the new neuroimmunologist in town, you'd be shocked at how many referrals start coming in. So even coming up and crafting, hey, this is how we're going to unroll it. We don't want to be overwhelmed because our goal is to still see patients within 1 to 2 months, whatever your timeline may be, can be helpful so that you don't irritate the people on the outside who are sending you patients. Use the trainees that are around you. If you have a highly efficient clinic, you can spend more time teaching, you can spend more time doing exams. It also helps decrease your note burden if medical students or residents, fellows are helping out. So really it's kind of a mutually beneficial thing where you can create an efficient clinic, which allows you more time to teach, which gets your students and trainees more interested, and then kind of that helps perpetuate them getting involved in research, wanting to come back and help you more. So really, making your clinic efficient will end up driving more trainees to be with you. And certainly, if anyone is in research, you kind of default have to be a good teacher as well, given the number of people you're going to be interacting with and how you communicate on your research as well. This is, I think, is the most important point about the clinical efficiency piece of things, is minimize your interruptions. When you're in clinic, you're in clinic. Try to avoid multitasking, taking away the emails, non-urgent texts, all of the other things, and focus on your notes and your clinical care. We're all guilty of it. We take out the cell phone, we have our email pulled up at the same time, but really when you're in the clinic, focus on clinic. When you're in the research environment or the lab, focus on the research. And tell your staff too, when you're not in clinic, when you're available. So I think this is an important thing. So leaving your Epic or your Power Chart open seems like a good idea, but it's actually incredibly distracting when you're trying to write something, research, do a biostatistical analysis. So, usually I'll recommend having your MA or your RN, if you're working with one of them, to know, hey, these are the things that are urgent, and I want you to text me if something like that comes up, but otherwise I plan on checking at 8 a.m., noon, and 5 p.m. And just limit the total amount of interruptions so you can get everything done at once.
Same thing with leaving your email open. That email pinging in the background, they've done a recent study that shows that makes you remarkably less efficient. Even if you don't actually check it, your mind goes to that point, and then you have to sort of refocus on what you're working on. So turn off the EMR, turn off your email when you're trying to write a paper or get something done.
Great point. Last piece on the clinical efficiency, work with your team. I know it kind of, especially for those of you that will be in situations where you're only having clinic, 2.5 days a month or 2.5 days a week, 1/2 day a week, whatever it may be. Meet with your staff. Go over, the frustrations, the obstacles that your patients are encountering, your team is encountering, you're encountering, and really having assigned roles can be a helpful piece of that. Who follows up the results? Who gets the prior auths? Who's managing the patients that need infusions? This comes up quite a bit with my patient population. And then getting patient feedback. Hey, how long does it take you to get called back once you called in? Hey, when you call our main number, are you being routed to the right person? How much time are you spending on the phone? What is the most efficient way that you want to communicate? And I'll say that this actually comes up because working with an MS population, most of our teens are kind of in that 12 plus age category. So I see very few young patients. And all of them have said, I don't even bother calling into your phone system because it takes too much time. Can you text me? And so now we're actually looking into ways to text patients, patient reminders, so that they know when they have follow-up appointments, when they have infusion center appointments, and that's actually cut down on our clinical burden because patients aren't calling in anymore. It's an automated system. So use that feedback that you get from patients and your clinical staff to help improve the efficiency of your clinic as well. Research efficiency. I mean, I'm a dork at the end of the day. I think many people who are sitting in on this phone call for obviously reasons would also qualify themselves as dorks, but keep a calendar. Have it written that, this is the time frame where I want to start thinking about organizing the things for a K-12, a K-23, an intramural grant. So that way you can kind of keep track of it. Keep track of abstract, publication deadlines, all of that sort of stuff, because the last thing you want to do is be getting that email from the AAN saying that the abstract deadline is in 48 hours, and then you're scrambling to send out and develop an abstract, or you don't have the right form. So stay organized, and I find a calendar is the best way to do that for me. It may be different for you, but find some way to kind of keep track of your upcoming dates. Recycle things. Recycling is good for the environment. It's also good for research. So I often recommend saving every draft that you actually ever write, because you never know when you can actually repurpose that thing that you cut out from your other paper or your other grant and actually reuse it for something else. And if you have a very detailed and organized system on your drive or your cloud, it can actually be very easy to go find what you had written before and repurpose it again. And same thing goes for references, using things like EndNote and saving all of those references so that you can reuse them later on. Don't be afraid to delegate and speak up when you need to do it. Know your researchers and say, I need help with my IRB. Hey, my research assistant, I noticed that you're writing down blood pressures in this style. I actually like them in this style. Communication and delegation of the tasks that you need done can be very helpful, because as much as you feel like you can do everything, it is maybe more efficient to have your staff or the people that you're working with help out with that sort of stuff. So I will tell you, I always screw things up on IRBs. So actually we have a clinical research coordinator that knows the people at the IRB, is very familiar with the process. So I send her the basics. She reviews it, sends me all the reviews, and we can, instead of having me bounce back on an IRB 4 times because I don't follow attention to detail, unfortunately, my research coordinator can get everything done in usually 3 or 4 days and get that in. So knowing who can do things better than you is going to be a very helpful exercise for maximizing your efficiency as well. And know thyself. I am easily distracted. Sometimes I feel like I'm a golden retriever. I just show up and I start wagging my tail because I get very easily excited. So when I need to actually get stuff done, I have to go to the library, and knowing that and being open about it with your chair, your chief, your program director, to say, hey, when I'm doing research, I need to be off campus for it, is okay. Because at the end of the day, your productivity, if you can get that extra 20 to 30% by avoiding distractions or not being around multiple screens at work, can be super helpful in terms of, especially in the paper writing process, but also if you're doing that deep dive into the data or doing statistical analysis as well. Talk to others. So even if it's not within your own field of research, I think that many times we say, well, oh, that person's in oncology, that person's in nephrology, what could they possibly know about my experience or my experiment? Use your mentors to actually network in for people within your institution and outside of your institution. If you're hesitant about sending an email, just send it and realize that you may not get a response, but in the best case scenario, you're actually going to get response. You may be able to get helpful details. That can be helpful from a research methods perspective. That can be helpful from, hey, you should be applying for this grant through the Celiac Disease Foundation, which you may have never thought of as related to your work, but they may be looking for something on that end. Hey, maybe you should be going to this conference or this other conference. So really reach out, be connected, be that networking person, because often it can really lead to some helpful things. I will say this, my K23 is on Down syndrome and endothelial inflammation. I did not know as much about endothelial inflammation, which is why we're submitting the K23, but in actually talking with an Alzheimer's researcher, I was able to actually get a better lab to run my samples, and it actually kind of changed really an entire specific aim of mine in the grant, just from kind of networking with this person who I thought had nothing to do with my original research. And I'm sure, Dr. Porter and Dr. Brooks-Kayal can, attest to that as well, of that, you really can get some great, innovative ideas from people in other fields within neurology and outside of neurology as well. And
often the thing to do is, often you can, even if you send the email to the wrong person, you can always say, if you don't think you're the right person to address this, be extremely helpful if you could, direct me to someone else who could. And often then they will just forward the email and your contact information to someone that they know. So sometimes it's 2 or 3 steps, but almost always in our research community, since we're fairly small, you'll be able to find someone that knows someone who can help you.
Exactly. Time management, be mindful of the time that you spend doing things. And really, I would also recommend that you set a limit of what you want to do, whether that is writing, whether that is, time for you're writing your clinical notes, really being mindful of how much time you're spending doing things, and then finding using that information to then later say, wow, I am spending way too much time writing my clinical notes. How do I improve that? Or, when I'm writing, it's that first hour that I'm distracted for, but those last 2 I get, most of my work done. What can you use to actually, get that data and then, reinforce it and say, how do I make this process more efficient? Going back to that whole PDSA cycle thing. And again, really minimizing the amount of multitasking that you're doing to improve that efficiency as well. You're going to get rejected. I think I already said this. This is really hard. When you get feedback, don't be the person like me who gets so enraged that I want to email back the editors at a particular journal and say, you guys don't know what you're talking about. This is the best study ever made. Read it, sleep on it, and then go back to it a few days later and really take the feedback seriously. I mean, if whether it's on a grant, a publication, an abstract, whatever it may be, really take that feedback and say, is this legitimate and should I incorporate into the research? Is this something that I should talk about, on the big picture perspective with my mentor, with my chief, my chair, whoever it may be, about, is this something structural that I'm thinking that I'm not anticipating in my research and it's coming back as a problem now? And then once you get that, you can use that to develop the next grant, to develop the next publication. And I think that what is going to be the most helpful for keeping you on track is not getting deterred by the rejection process. That's part of academic medicine, and it always stings a little bit because we all think our research is really great, but the idea of that review process is really designed to make your publication or your grant or your end research better. And so we'll always kind of keep that in mind. So in summary, don't freak out. Be organized, make sure you have the right time and the right environment to do the work that you need to do. Be efficient with your mentors, especially on the communication front. Use technology to your advantage, talk to IT, develop those smart phrases, develop those templates, save yourself time, in that setting. Always, keep track of your research pipeline, know the dates, keep a calendar, use whatever strategy works best for you so that way you stay on top of things. Minimize your interruptions, and as Dr. Brooks-Kayal was saying, and myself, say no, but say it respectfully, because you never know when you're going to need that person again. So you can say, this sounds interesting, like an interesting project, but I don't know if it's the right time, but and then also keep that networking piece as well. So I'd love to revisit this in a realistic time frame, or when this grant goes through and I have 2 or 3 months, why don't we sit down and we can talk about it again. So strategic yeses and saying respectful no's are a big piece of especially that early career process. So I think that's all I've got, but I'm happy to answer any questions either through the chat or through the voice system.
And just as you're thinking about your questions, this is Amy again, the one thing that is really beneficial to knowing when to say no is that you will get a reputation for following through. The problem with saying yes when you're not going to be able to get something done is then you're not going to get it to people. You're not going to get a good work product to people on time. And it's better to be known for only saying yes once in a while, but when you do, you can be counted on, than, being known as, she'll say yes to anything, but she won't actually get it done when she says she's going to get it done.
I have a question.
Yeah, go ahead.
So one of the things that I really struggle with is cognitively going back and forth. Between research and the clinical side. So it's not so much, I'm really lucky. My program very strongly protects my research time, and I just have 1/2 day a week of residence clinic and then 4 weeks a year of on-patient service. And when I'm on service, it's really only in the mornings. But I have a lot of trouble being clinical in the morning and like seeing patients and thinking that way, and then being productive in the lab in the afternoon. More mistakes, I'm slower, I'm less efficient. Do you have any recommendations for that transition?
So this is Amy. I would say what I always did clinic in the afternoon. Because for that same reason, if you go to clinic in the morning, one, there's the clinical suck that just keeps you there and doesn't get you out. And also because you are thinking in the afternoon, you're thinking about the patients that you saw in the morning. So I would say try whenever you can to make afternoon clinics. And if you need to do 2 half-day clinics a week, put them on the same day. So you devote 1 whole day to clinic. And then the same thing with answering messages. Find out from your program director how often you have to answer non-urgent messages, but if it doesn't have to be several times a day, if your nurses or MAs can page you for urgent things or text you for urgent things and you can just answer once a day, do that and try to answer, towards mid to later afternoon. You don't want to leave everything to the end of the day for your nurses to take care of, but if you can put that later in the day, that often will again help you think about your research during the day, and then just reserve the thinking about clinical stuff till later in the day.
Thank you.
Personally, Friday afternoon, I always do clinic on Friday afternoon. Just always pick Friday afternoon. Nobody wants it but you, and you're not that productive anyway, so just do it then.
This is Yula. I also give myself a list of mindless activities that don't require a lot of cognitive output, and I do those when I just know I can't do anything complicated anymore, but at least you get a little bit of something done, and makes you feel much better.
Why do you go to your message system 3 times a day, Jonathan? That seems ridiculous. Like
it is, and it's probably unnecessary. The way that we do it is that we're piloting a system where it goes to kind of a doctor of the day instead of actually having the actual independent physicians check it. They have done that if you're on vacation, but they have not done that if you're in the research setting, and that's mostly just because I'm the only researcher here. So, in time, we're hoping to move to that system, but otherwise, the expectation has been to check it at a minimum 3 times. Usually it's nothing in the morning, so I'm checking, but by noon at the end of the day, there's usually
ridiculous. Nobody should check their messages that often. It's just like, come on, get real.
I agree.
Yeah, and again, we are physicians, so there are urgent things, but working with your clinical staff to know that they should call you with anything that needs to be answered in less than 4 hours, you know, or text you or whatever. Because the majority of the time things can be answered once a day in you know, like you know, in a reasonable time in the afternoon.
And almost always somebody fixes it for you if you wait.
That is very that is very true. But actually, I think one of the better things is, as Amy was saying, is that, you know, my nursing team now knows these are the 4 things that can't wait. You need to call me or page me immediately, and that has really reduced the number of interruptions throughout the day, which has been very helpful.
When you negotiated your package, Jonathan, was there a point where you said yes to something that you didn't really want to, but you got something back in return? Because I always think, especially if you're talking to your boss, you can say yes, but say, you know, this isn't going to really provide, I mean, I need to be provided with some protected time. So recently I sort of held out. I was offered this position with no effort. And I just kept saying, no, I don't think I'm really the right person at that time. And eventually they coughed up some effort.
Yeah.
So saying no until you get something.
Yes, and you know, I think that what I walked in, I think that that's, you know, that earlier slide where I was showing you that kind of projections of what, you know, what were my 5-year marks, what is the breakdown that I wanted. I mean, when I made that, I made it as this is the minimum I would need to do what these things are. And so, yes, the negotiation process was very much, well, you know, you could probably sneak in 2 extra half-day clinics and, you know, all of these other things. And with those, it was a very hard no to say, if you want me to develop a, you know, a research program in neuroimmunology, this is how much time it's going to take. And we don't have anything, so it was very easy to do that. But I would say, you know, when you're kind of crafting those things, be very specific to say, within 3 years, I want to do this, this, and this within research. I want my, you know, K-12 or my K-23 or my R01 to be in these time frames. And I think that when, you know, chairs and chiefs are looking at that information, it can be very helpful for them to say, like, all right, this person is asking for this protected time and this plan seems reasonable. Or they say, listen, this person is requesting all of this protected time and these plans either seem too ambitious or are, you know, not even close to what we would, you know, use that amount of protected time for. So, you know, you have to be a little bit hard-lined and be the squeaky wheel to actually get the protected time. But if you're worried about that negotiation process, you know, it sounds, again, a little bit dorky, but practice it. Practice in the mirror, practice with your, you know, significant other, with family members. Go through that process and feel comfortable asking for what you need to succeed. Because at the end of the day, it doesn't make any sense to stay in academic medicine and, you know, take the pay cut and, you know, work really hard if you're not going to be able to perform and you're just going to get burnt out at the end of the day.
So it's always good to remember when you're negotiating with someone sort of what their thoughts are on the other side of the table. So as a person that is the one that has to decide who can get protected time, because I can't give it to everyone, the things that I want to see is exactly what you said, John. I want to see a timeline. Exactly what are you going to do? Metrics, like I'm going to publish this paper by this time, this paper by this time, this grant submission is going to go in at this particular point in time. And often, you know, and then if it, you know, so even if they can only make a commitment of a year or 2 of support, if you meet all of those metrics over your first year or 2, it's much more likely that you know, whoever you're negotiating with is going to work real hard to find additional support, because you're on a trajectory that suggests that you're going to be successful and you're going to do what you say you do. But there need to be specific plans and specific metrics of productivity, just like we have for clinical, right? For clinical, you expect to see so many patient visits or so many clinics or inpatient weeks for a certain amount of clinical productivity. It's exactly the same for research productivity. We want to see specific metrics, and we want to see you achieve those metrics if you want to continue to get support for those. The other way to approach it is if after the initial negotiation, if your time is pretty much filled up, like Brenda's is, and someone comes after you and asks you to do something else without protected time for it, list all the things that you're currently doing and say, look, at right now I'm 100% committed, you know, to your supervisor. Which of these things that you've already told me are important to do you want me not to do in order to do that? right? Because that's really the key to just having things piled on top of each other, is really to say, okay, if this is mission critical, you really need me to do this, which of these other 4 things do you want me to not do during that time?
Great point. And I think Dr. Levy has 2 questions on the chat. First one is, what should we be asking for as far as ancillary staff support? And I think that this obviously is going to be very specific to the institutional environment. For me, my thought when I was kind of coming up with what I would need is that my patients, because I'm only doing neuroimmunology, are very unique. They really required kind of an RN level experience for triaging many of the questions. So I asked for a dedicated RN for my clinic. Which was doable in my situation. If you're doing general neurology clinics and it's mostly headache, developmental delay, you may not need an RN for it. You can get away with an MA or an LVN who are kind of providing support, but you can get these things. And then additionally, a lot of people have asked, well, what about an MP or a PA? Absolutely, you can, ask for the moon, but you also have to have some numbers to back it up, to say, listen, I'm going to do a full day a week. I'm going to do every Wednesday all day in clinic. And in a year or 2, I would anticipate having enough volume to support a PA or an MP for that clinic. In people who are doing research, heavy careers, they may not give you a dedicated, APP, but it is something that you can certainly consider and ask for and put in that initial plan, so that you can reference it at year 3 when you say, look, our clinical volume is too high and my wait list is 6 months. Can I have an APP? I think we could sustain this in whatever setting it might be. Dr. Levy's other question was, nice way to be efficient at work, but how do we have home life and see our kids every now and then? How do you all balance that? I mean, for me, when I leave the hospital, no matter if it's a research day or a clinic day, I turn my phone off until 9 o'clock at night. And then whatever is remaining from the end of the day, I usually take care of at that point before bed. That may not be the best style for everybody, but that has worked for me because I've realized that when I'm with my wife and my son, I like to actually not have to be answering text messages or responding to emails or looking at my phone every 30 seconds. They seem to think that that is not showing attention to them. So that has been my strategy, but I'm sure many other people have different ways to approach that home balance life as well.
Amy told me when she was my boss that when you die, nobody's going to care about your research. They're only going to care, about your kids and your, family. And I thought, that's good advice. So I basically figure they're first on the list, and then everything else is kind of second.
Yeah. Also, when you die, no one's going to care about your RVUs. I hate to say that as a section head, but that's also true.
Good point.
But Jonathan, I think what your comment is exactly correct. Be present, right? Just like we talked about, when you're doing your research, do your research. When you're in clinic, focus on being in clinic. When you're home, be present for your family. Like, don't be checking your emails. I would say don't be on your phone. Don't be looking at patient messages unless you're on call. And you may, I think many of us had once the kids are in bed, getting back on, reconnecting or getting messages done or doing a little bit more for an hour or so before bedtime. And I think that's not unreasonable. But make sure to block that time to be with your family, if not every day, at least the days that you're not specifically on call.
And also try to anticipate the time that you'll need, especially on weekends. I mean, occasionally you're going to have a grant that's due and you're going to need that extra, few hours on a weekend to get things going. So the way that I actually do it with my wife is I send her a calendar invite to know that, for these 4 hours on Sunday morning, I'm going to need to, prioritize it for this week. It can be hard sometimes to anticipate that sort of stuff. But again, if you're in that situation where, and this happens to everybody, if you're in that situation, try to make it as a chunk of time, because if you're running back and doing, family and then some research and then some family and then some grant writing, it's both are going to suffer for it. So try to, again, just like during the week, try to block it out and just get it all done at once if possible.
All right, we're at our limit of time, but I want to make sure we thank Jonathan. You did a great job. I really appreciate this.
Yay!
If you have any other
Thank
specific
you.
questions, you can certainly reach out to him, I'm sure. And he will
Yeah,
answer
no, and
that 3 times a day.
I'm also happy to send over any information, with regards to like how to break up schedules when you're looking for jobs, or especially that timeline in residency and how to catch up, because certainly my experience was not the person who showed up in residency and said, I definitely want to do research right away. And I actually distinctly remember meeting with Dr. Porter when I had come out for my residency interview and told her I never wanted to do any research and I only wanted to be a clinician. So times change, things change. And if you're feeling like you are behind, that's okay. And I'm happy to, answer any emails or help out with somebody who's feeling that.
Okay. Thanks so much, everyone.
Thanks, everybody.
Bye.
Thanks, Brenda. Thanks, John.
Bye. Thank you.